Hi everyone, and welcome to episode 42 of Now and Men, the podcast on men, masculinities and gender equality. Hi Stephen, how are you doing?
Hi Sandy. Yes, I'm coming to you from the land of the boomerang people, and I'm well, thank you. If still perhaps a little bit sleepy, as it is quite early in the morning here in Melbourne, because our guest for this episode is based in the United States. But how are you, Sandy?
Well, funny you should say that, Stephen. I'm a bit sleepy too, as it's 10 p.m. in the evening in the UK, and I've just got back from a fascinating book launch about potholes and pavements, but I won't say any more about that at this point. At least our guest should be awake, because he's, as you say, in the US, and it's late afternoon there. So he's Professor Derek Griffith, and we're delighted he could join us. Derek is a founding co-director of the Racial Justice Institute. He's founder and director of the Centre for Men's Health Equity, and Professor of Health Management and Policy and Oncology at Georgetown University. He also serves as the chair of Global Action on Men's Health, which is a global men's health advocacy organisation.
Yes, and Derek is trained in psychology and public health, and he's been recently praised for his leadership in addressing the impacts of racism on the health and well-being of the nation in the United States, and specifically for African American and Latino men. So hi Derek, it's great to have you with us.
It's a pleasure to be with you.
Hi, Derek. So this episode coincides with International Men's Health Week, which runs, I think, from the 10th to the 16th of June. I understand it began in the US in 1994 and then went international from 2002, and now it's been adopted by many countries, including the UK, Australia, Ireland, Denmark, Canada, and beyond. So why is Men's Health Week important? Why does it matter?
Yeah, thank you for the questions. I think Men's Health Network was the group that organized it at first. And I think it was simply because, we don't have a lot of efforts that really highlight and center men and men's health. And typically, both in terms of the narratives as well as just the attention that it gets, particularly from a gendered perspective, that we don't tend to have that focus. And so I think they, as you aptly noted, are building it right up to the week up to Father's Day as a way to just raise attention to different aspects of men's health.
So sometimes when we talk about men's health, it can be in quite sort of general, monolithic terms. I wondered if you could explain to us a bit more about why we need a sort of intersectional understanding of men's health and well-being, which addresses the differences which exist between different groups of men rather than just between men and women.
Yeah, this has been sort of the anchor of my focus soapbox career for a while. And it's really just because when we treat men as though there is one sort of universal man, or that men are a monolith, that we know from particularly a health perspective that their health is not equal. That there are definitely, rates of developing and dying from various diseases and, various conditions and opportunities to be healthy that vary very much by a number of factors, any number of factors, from disability status to race, ethnicity, sexual orientation, gender identity, you name it. And we don't tend to look at men's health through that lens, and therefore we miss opportunities to create policies and programs that actually speak to those issues, or that are going to help improve men's health as an overall population. So said another way, it's going to be really difficult, or it is difficult and arguably potentially impossible, to improve men's health by just having a one-size-fits-all strategy, because there is such heterogeneity in who we're considering under this tent or umbrella of men. And because the what intersectionality highlights is how diverse some of the determinants of health are, the drivers of health are, for those different groups of men that intersect with sex and gender. And so that's what really an intersectional lens offers. The other part is it helps to focus on the structural conditions and factors that contribute to men's risk and the larger sort of drivers and determinants of health, rather than it just being about men's beliefs, attitudes, and norms.
Perhaps could you say a bit more, Derek, about what some of the ways are that those kind of intersectional inequalities manifest themselves? Perhaps in your home country of the US context.
Yeah, unfortunately, part of the ways that we see these intersectional identities and structures differ is that we see very different life expectancies. We saw different effects of COVID, both morbidity and mortality, very much by race, ethnicity. You see the differential benefits of things like education, whether it's college, differential rates of having within each level of education, different returns on that investment, if you will. So you have different folks depending on their combination of race, ethnicity, and gender, that you'll see different benefits or different levels of income, on average, that you'll see at those different levels, even with the same level of education. So both in determinants and drivers, as well as in terms of the downstream health outcomes, you see really different ways of um, that these manifest themselves.
Mm, Well, yeah, and going a bit more into what you just said, yeah, could you perhaps say a bit more about why it is, or how it is that racism, structural racism, systemic racism, everyday experiences of racism do actually impact upon the health and well-being of men and boys of color in the US?
Yeah, I mean, structural racism is really similar to what I was saying about sort of race being an umbrella. That structural racism is kind of, in my mind, sort of the glue across different sectors of society or institutions. And it helps to explain why, whether it's the criminal legal system, education system, healthcare, um, economic factors, that all of these are sharing a similar pattern. And so, why is it the same groups tend to be disadvantaged and even advantaged in those systems? For a long time, we just talked about racism, and there's one of the efforts in the U.S. context has been to redefine what we mean by racism by some, to think of it more as intentional, as think of it more as only those things where somebody does it with the very explicit intention goal of oppressing somebody else. Structural racism looks less at intention and more at impact. And so it's really about understanding, how do we understand and make sense of, and therefore can intervene on these patterns that we're seeing across sectors, across time, and across place. Yet they're all still, patterning in the same way. In the U.S., we see these patterns, basically continuing to persist, and we see it particularly, when we look at whether it's leading causes of death, particularly things from chronic disease and COVID being one of those leading causes of death these days still. We see these patterns sort of co-occurring. We did a paper a few years ago where we combined an intersectional lens and what's called syndemics, which is basically trying to understand why do these structural conditions link with two things that don't really make a lot of sense that they should co-occur. So why do things like stress, depression, COVID, and things like heart disease, why would those, constellation of things, when they have, different biological things that would actually contribute to them, why would those co-occur under this umbrella? And so syndemics basically says, what's the mechanism? And so it was a stress mechanism that was rooted in anti-Black structural racism that helped to explain, well, why is it that the concentration of Black Americans are in a particular area where there are a lot more stressful conditions, fewer opportunities and so forth, and the clustering of risk as it related to COVID. Why do you also see the clustering of risk as it related to hypertension, heart disease, and those kind of factors that we also characterize as pre-existing conditions for COVID and so forth? That it's that combination that helped to explain why Black men were dying disproportionately from COVID during that period, why they had sort of a shorter life expectancy before COVID, and then it was exacerbated more by COVID. And then how do we understand those kind of contexts and pictures?
I was just wondering, where masculinity fits in with this as well, because, there are masculine pressures, expectations that do shape men's health and well-being, and are there differences across different groups as a result of different constructions of masculinity, if you like?
Absolutely, absolutely. One of my favorite papers from now, 15 years ago, about was from Tony Coles, who was at University of Tasmania, maybe. It was something in Tasmania. So don't. I apologize if I'm
We can put it in the
butchering
show
which
notes.
institution. Yeah, but he talked about this idea of mosaic masculinities, which is basically mosaic masculinity, which is basically the idea that men know what these broad sort of structural norms, expectations, beliefs are that are supposed to be attached to identifying as a man or being biologically male or both. Yet they may or may not actually buy into them. And we tend to pick and choose which things, we acknowledge all of it, but we tend to pick and choose more individually which things are actually important to us, which things we actually see as important to our values, beliefs, and who we want to be seen as. And so intersectionality provides a tool to basically take how do we think about those gendered ideals that you were describing and bring them into other structural conditions that shape how we think about the world, like race and racism, like homophobia, like other factors that are those things that combine in unique ways so that men sort of see themselves in certain ways. So, and there's often different histories as to why there are different values to particular aspects of what it means to be a man. And so there is actually a different literature for black manhood, essentially, as an example, than necessarily on the work that, say, Michael Kimmel does on American manhood and so forth. And he talks about in some of the beginning of his books that this is about essentially middle class white male masculinity, that this isn't necessarily something that generalizes to all groups. And even Raymond Connell, their earlier work talks about some of these differences, that some notions, particularly of what it means to be a man, may vary by setting and by marginalized status, and how those factors may contribute to folks having very different experiences, exposures, ways of defining, what's important to them in these different bodies and different identities that they sort of choose.
I wonder if you could say anything about how you might see Black American masculinity then. What kind of components would you say make up that?
Yeah. So one of the papers that I built my sort of way of understanding black manhood off of is from Tony Whitehead, who is an anthropologist. Spent a decent amount of his career at University of Maryland. I think he might still be there. And he talks about, he did, observational research and actually, do as anthropologists do, actually spent some time both in Baltimore, Maryland in the U.S., but also in Jamaica, and found similar patterns of black men. He talks about two things. One is sort of reputational and respectability as sort of two components of masculinity and manhood. Reputational is basically a lot of the things that we tend to associate with traditional masculinities, the ways that men sort of may behave in certain ways that would show strength, power, like being able to fight, like being able to drink somebody under the table, being able to, put their bodies through all kinds of stuff, drive a car blindfolded and backwards or something. Like all these things that we just sort of, you have this crazy reputation for being able to do something, but it gives you more status because you can do this insane thing or this thing that is, likely not necessarily the most healthy thing in the world. Respectability is the idea that you're also combining that, particularly as men age. And if you think about what middle-aged and older men sort of value and see as important, it's usually not necessarily those things about being able to drink to excess, eat whatever you want, smoke everything. It's more, am I a good parent? Am I a good co-parent? Am I a good partner? How am I doing in contributing financially to my household? Am I a good member of my community? So it's about, trying to embody these characteristics of respectability and these things that sort of say that I believe in certain values, I have certain ideals, and certain things that are the anchor of who I am, even if you don't necessarily know me well. These are the things that people speak about me when I'm not in their presence. And so it's really those two anchors that I
Yeah.
see
Yeah,
with
that's
Black
very very
masculinity.
interesting. I haven't heard it explained in that way before, but it makes a lot of sense. But I'm also wondering to what extent. I mean, you mentioned risk behaviours, drinking heavily, taking drugs, dangerous driving. I mean, these are traditionally seen as key explanations for men's poor health. That remains true, doesn't it?
Well, I
Or
don't.
not?
So it's been interesting. Yeah. So there are definitely things that cluster in males and men. We know that, I think there are more than 30 behaviors. This is an older stat that men would engage in that women would not, that have adverse implications for their health. When we combine that though with the larger literature on health inequities, health inequalities, and so forth, that literature says that behaviors tend not to be the largest drivers of things like morbidity, mortality, and certainly not life expectancy. So it's really combining those two that I'm sort of suggesting when we think about things like intersectionality, men's health equity. It's really that combination that it's really more the structural conditions and structural factors that shape
Right.
or constrain the choices that men have as to what they eat, what they drink, so forth, that have implications that we don't tend to capture when we focus on just the behaviors,
Right.
the downstream behaviors in that way.
Mm, mm. And how significant is it then that men are much less likely than women to use health services? Is that to do with being reluctant to seek help, and perhaps they present later and with more severe symptoms? Are these also part of that picture?
They definitely are. I mean, I think, but there I think are two sides of how to look at it. When we frame these things as more issues of men, then we kind of take some of the responsibility off of the system to see how it can be more effectively structured, framed, presented to men. So one of the things we don't tend to do is think about how are healthcare services, opportunities structured and framed and presented to men, or consider gender as it relates to males and men. How do we think about what those things are? Do we have clinics that are beyond focused on things like erectile dysfunction and related things for men and men's health? Or is it just about defining men to be synonymous with those kind of factors? And so part of it is it's not necessarily clear that, let me say it's a different way. One of the things we did some years ago now is did some focus groups. And one set of questions that came out was why, in our case, black men didn't go to the doctor or why they didn't seek medical help. And they talked about, there were reasons before they went, there were reasons why what they experienced, and reasons that they didn't return. Essentially, the short version is they didn't essentially find value in it. They knew, they would get advice when they would go to the doctor that, hey, you need to lose weight, which definitely is an important thing, but it's something that they knew before they got there. And usually they weren't necessarily given resources to make the change that they were talking about. And so when they would return in 6 months, they've actually gained 5 pounds as opposed to lost the 10 that they were told to lose. They have a very negative interaction with the provider and, often get scolded in a way that feels, disrespectful. And so then there's like, well, this is kind of pointless. And so some of it is also like they did value the tests that they got, the information that you can't just get by, you know, looking at yourself or seeing how you feel and so forth. So they did value those things, but it was more that the experience of it was not one that they found terribly helpful. They didn't feel comfortable asking certain questions because of the response in some ways that they got to those questions. They didn't see the providers didn't always seem like they genuinely wanted them in to ask questions. We know by race and ethnicity that the visits sometimes tend to be shorter, and certainly that's the case for men. They ask both the doctors ask fewer questions, the men ask fewer questions. So there's these other sort of markers of the experience within healthcare that are just different, are just qualitatively different for men that we have to consider. How do we think about those factors when we look at why men have these differential patterns from women?
That's very interesting. I mean, that's about the interaction between the health service and the men themselves. Yeah, because I was thinking also in terms of things like opening hours for surgeries. If men are at work, then can they get there, and do we need to look
Mm-hmm.
at extending that to make it make health services more available, and so on and so forth. So that I guess there's a range of things that need to be looked at, aren't there?
Yeah, and even I think the messaging. One of my other long-term favorite papers is from Steve Robertson. He talks about this don't care, should care dichotomy, and that on the one hand, hopefully, Steve, I'm not butchering this if you listen to this, but but the idea is that we have this norm and expectation that men should care about their health, but then we also value them for acting in certain ways where they don't actually care about their health and they don't actually show that. And so you have the other part of that was he borrowed, I think, this concept of male body schema from a scholar named Watson, where it's basically there are different components of how you think about what it means to be healthy. So if you ask somebody, hey, how you doing? Oh, I'm fine. So that's one level of health is how do you generally just feel overall, just as a big gestalt, how are you doing, how are you feeling, and whatever. The other part is more the functional, can you do things that are important to you? And that's often when men do go to the doctor is when stuff doesn't work, whether it's sexually, whether it's at work, they can't function well. Something is much more about an instrumental sort of thing that they can't do well. But when they go to the doctor, that they often are talking about, they don't engage with those two areas. They often talk to men about sort of biological mechanisms that they can't see, feel, experience, or anything like that. And so if we could talk to men about, you want to be able to have more energy, at home, to not just be part of the furniture with your kids and as opposed to just having them jump up and down on you because you have no energy to play with them once you get home. If you made some of these changes, then that would actually help with that. So if we link these conversations, if we bring down, your A1C level in terms of diabetes, if we get your blood pressure under control, it will give you more energy, more focus, more whatever that's important to you. And so it's really linking these conversations and these tools in ways that could be really helpful. And so that's some of the mismatch, I think, between some of the ways healthcare could be and the training of healthcare professionals could actually improve to help address those kind of issues in men.
Of course, one way in which inequality has an impact is in terms of economics, right? And I was thinking about the situation in the US with regards to your healthcare system and the fact that there are big inequalities there in terms of people's ability to access healthcare. I mean, would you say that that's a factor here in the differential rates that we see in terms of things like mortality?
It definitely becomes sort of a vicious cycle. If you don't think you're going to, again, this is where the historical look becomes important. So if you know that you came from a system that many sort of men who were retirement age grew up in a system where they didn't have equal access to healthcare. And so there was a racially segregated healthcare system where it was not just separate, but it was actually by design and by investment a lower quality system. They had fewer resources, it wasn't as good, longer wait times, longer everything. And so if that's how you're trained to start thinking about the value of healthcare, it's like, and then you fast forward, generations, and that's what you're using as the model to train your kids, your grandkids, and so forth. It's a really different sort of way of thinking about why would you go to the doctor in the first place, or why wouldn't you just wait until something is falling off, not working, what have you. So that combination plus the structural conditions, I think, do contribute to exactly what you're describing, the huge inequities in healthcare, the huge inequities in healthcare costs, that folks utilize. Another older paper, again, another favorite, is by a colleague, Roland Thorpe, who's at Johns Hopkins. He did a paper about the cost of men's health inequities. and looked at it through the lens of the cost of utilizing different aspects of healthcare, just how much it costs to do different things and so forth. And what he found was in the hundreds of millions of dollars, that there was that huge of a difference between different groups. I think it was 340 something $1 million that was different between sort of black men and white men, I believe, and even other groups of men. Because in our case, even though we tend to think about white males as sort of the standard, they don't necessarily in the U.S. context have the best health. And so he tried to do it relative to who had the best health, not necessarily just the traditional standard of looking at white men and just basically basing everything off of that. And so it was really Asian American men who had, I think, the best health. And so if we were able to bring the standard of these other groups like black men up to the standard of Asian men, what would that do to the cost of healthcare? What would that do to things like life expectancy? And it would, make all the difference in the world.
Yeah, so as we mentioned at the beginning, Derek, you are the chair of Global Action on Men's Health. And so you launched a report in April of this year, which concluded that men are largely absent from the mental health policy produced by many of the kind of leading organisations on global health. So yeah, we were just wondering if you could tell us a bit more about why that is and what we can do about it.
Now, the why that is a more complicated question than I can answer. So all we try to do is characterize, because that is part of the question. Is in all seriousness, we've talked about men's health as something that is constantly hidden in plain sight. It's something that we have a lot of data. All the data points to the same thing, that men have worse health outcomes in most things that will lead to premature mortality or lead to mortality, yet we don't actually tend to focus on men's health as an issue that we need to address. And so this report, and we did one on cancer recently as well, and so they point to basically the same thing, that when we include gender in these discussions within these documents from various national and transnational organizations, that they tend not to, they'll make broad reference to gender, but really not necessarily mean people of all genders, and certainly not mean men in that picture. And when men do worse in those contexts, there's a lot less actual explanation for why that is or what should be done than when women are doing worse in those particular contexts. And it's within the same document. And so the why is part of why we're raising the issue, is that, there's not really a good reason per se, or certainly not a practical one, that would explain that.
I mean, do you think it's partly, I'm thinking back to an episode we did a few episodes ago with Dr. Jocelyn Smith-Lee, also in the United States, where we talked about, it was actually the impact of kind of trauma on young black men in the US, and I suppose the discomfort we have, in the United States, about talking about vulnerability, I suppose among men in general, right, but perhaps especially among black men, because that goes against these kind of stereotypes that exist in society. Do you think that's part of it? This discomfort with the idea of men being vulnerable, that doesn't fit with the ideas and expectations we have about men?
It definitely fits with the notions, the ideologies, and so forth. Part of it, though, I do think that's relevant or related is that some of these issues very much speak to the way that we frame the problems when men do worse, that we tend to still look at that as the problems of men's individual masculinities, the way that we interpret, make sense of the world, the way our attitudes, beliefs, values around men's roles, the way that men should embody what it means to be a man, and so forth. And that's usually the way that we explain when men are doing worse. One problem with that, not to suggest that there's only one, but one of the problems with that is that it, again, gives no room for the healthcare system, for policymakers, for public health to actually have a role in fixing it, because there's nothing for them to fix. It's the problem of men And if we just fix men, then the problem is solved. So there's nothing that we need to do differently, in our professional roles. It's just how do we come up with strategies, policies, programs to fix men. And so I think that narrative, or that sort of understanding of when men do worse, that this is not a problem for policy, this is not a problem for these organizations to deal with. We just need to fix the men themselves, and they will get healthier.
And are there any kind of particular policy changes that you think are urgently needed in this regard, whether that's in the US or more broadly? Are there any countries which you think are getting this right in some ways? Yeah.
Well, there's certainly, I believe, 9 countries that have had a men's health policy. So they're all very different, but that are really explicitly putting men's health on the agenda. I think that is, again, a partial solution, but not the only one. I think another big important thing that we don't tend to do is sex disaggregate data or gender disaggregate data consistently, and certainly not do it where we intersect sex and gender with the ways that we think about other dimensions like race, ethnicity, socioeconomic status, and so forth. So if we made a practice of presenting data always with that intersection of these subgroups, because it's things that we already are collecting. So I'm not asking for more data, I'm just saying present it in more fine-grained analysis. That will help us to better identify who's doing worse. And if it's something that is you see as a universal pattern across males, that's one thing. But you usually will see that certain groups are doing well, certain groups of men, in this case, are doing even worse, or where, again, subgroups of women are doing worse, and folks who don't fit this gender binary, may be faring not so well either. So I think that the sex disaggregation, gender disaggregation of data, and the intersecting it with other data as a way to monitor, inform policies would be something that would really be a way to truly embody this gendered way of thinking about what these issues are.
I think it's right that some of your research has focused on prostate cancer. Is that the case? And so I wanted to ask you a bit about that. I mean, it's, as I understand it, it's the second biggest cause of cancer death for men in the US after lung cancer, and also quite big here. So could you tell us a bit more about how masculine norms perhaps impact on men getting this disease identified, treated, and what consequences it has for how they see themselves?
Yeah, so one, I think just contextually, one of the things we haven't done as a scholarly community is try to really push ourselves to think about why would masculinity be related to different health issues in different ways. So that masculinity is related to, again, we said 30 or probably plus health issues that are harmful to men's health. But how it affects, fast driving is very different than how it affects whether or not you go get screened for a colonoscopy, is very different than whether or not you monitor your blood pressure. And so being more attentive to how do we explain this relationship between masculinity and these issues is something that really the field needs to really put more investment and time into. In the context of prostate cancer, we have to also realize that there's probably a better way for me to say this, but homophobia is a big part of the ways that certain groups of men define what it means to be a man. And that it's that a lot of masculinity is not defining who you are, but who you're not. So it's this relational definition that you're trying to basically say, I'm not gay, I'm not a member of the LGBTQIA community, I'm not a woman, and I'm not a boy. And so it's not that you're trying to show that you are these things, that you are a man. It's by default, or by the math of, okay, I'm not one of these things, therefore I must be this. And so because of those fears, those are also things that really men, particularly when it comes to prostate cancer, if you can't function sexually, or if you're afraid, okay, I don't want to get this treated because it potentially has these adverse side effects of both urinary incontinence as well as sexual dysfunction, so I'd just rather live with it. Or with the old ways of screening for prostate cancer using the digital rectal exam, a lot of men were just like, no, because of their, what does it mean to my manhood if I let a doctor in a medical visit stick their finger up my rectum to check my prostate? Does that somehow another mean that my sexual identity and orientation is somehow another different because I let a doctor do that, regardless of the sex of the doctor? So, like those kinds of things, we find the same thing with colorectal cancer, even though you don't screen that way, but the same issues with having certain things, focused on your rectum is definitely something that men tend to really have issues with when it comes to screening for different things and dealing with it. And so with prostate cancer, a lot of the norms around associating health with functioning, particularly sexual functioning, urinary functioning, and those kinds of things, I think do really shape how we think about, men's willingness to go to the doctor for certain things, willingness to get it treated, and so forth, and willingness to just follow certain treatments. But now that we have, a broader range of tests, now that we have, a broader range of treatments, that we're in it's an interesting time to be in this space, since we had a period where prostate cancer screening was seen as something that you should do with the prostate specific antigen and the digital rectal exam. And then because of, in the U.S. context, the U.S. Preventive Services Task Force basically said, oh, this was not effective when they looked at all the studies. And so they basically said, okay, we shouldn't be doing broad scale screening for men who are not symptomatic. That we went through a period of more than a decade where we didn't do screening. And now we're sort of saying, okay, well, the data seem to be trending in the right direction. There's at least more evidence that screening actually is effective. So now we've picked up screening again. Well, the problem is that's really confusing to men who sort of, if you're like, okay, I don't know, am I supposed to screen? Am I not supposed to screen if I'm not symptomatic, if I don't have, high risk factors? And what age am I supposed to screen? Those are changing too. So it went from 50 to 40 in certain groups. And so it's like there needs to be, it's more complicated for particularly certain groups of men to know what are they really supposed to do in this time, because it has changed, in many cases in my lifetime 3 times. And so it's like, how are you supposed to know which thing you're supposed to be doing? And so we have to put more energy into dealing with that, but also, as you were saying, to thinking about how do the masculine norms, how do we make sense of that, and what are the kinds of things that men, when they get it treated, when they get screened, that they see as important, that we need to consider and that we need to educate them about, as part of that, helping them make an effective and informed decision about what those kind of things are. The last thing I'll say is women tend to play a critical role in this. We did a paper some time ago that looked at, so meta-analysis is quantitative, meta-synthesis is qualitative. And so we did a meta-synthesis of the role of women in men's prostate cancer screening and treatment. And basically we found that it maps onto, the ways that we think about social support, that some, are very instrumental. They'll help make the appointments. Some are really, it's just more the emotional support of, I love you regardless of whether or not you can function in certain areas of life. So it's just, some are just more practical and like, helping to support other ways of them doing. It's more emotional support. So the point is that we have to look at these things and look at even the gendered ways of looking at it in context. That it's a lot of, and this is John Olaf's work, that it really is about the social context of how we make sense of these things and the other people that help to inform. So these gendered ideals are not just about men absent the social context of, how they think about those things, but it is really informed by how do other people respond to you embodying masculinity in a particular way, and what are their norms and expectations that are going to shape how you actually respond to these things as well. So it's the whole context of, prostate cancer gets to be its own particularly complicated thing because it does get to the heart of, for some men, they're not men anymore if they can't function sexually. They're not men anymore if they can't control basic, bodily functions like urinary control. So that why would I still want to live if I can't function in this area? So it does get to the heart of what it means to be a man if you can't function in key areas that so many men will often define, perhaps ill-define, as being so central to their manhood.
Right. Do you think the same arguments would apply to, say, bladder cancer, testicular cancer? I mean, it sounds like they would, really. But there seems to be more of a focus generally on prostate cancer. But
yeah, I think it's because it's more common, and at least historically, the screening tests and the digital rectal exam, I think, was what would differentiate definitely testicular and prostate cancer. That you weren't that's not how you would screen for testicular cancer. So I think some part of it is both the prevalence of it, the mortality rates from it, the age at which you get it. Testicular cancer, as I understand it, is really much more younger men. Prostate cancer clearly tends to be for those who are in the older sort of phase of life. So I think there are a lot of those kind of factors that contribute to it and make it a little more nuanced. But I think the point, and the broader point that you started with about how do we think about gender as it relates to these issues, we need to better understand, well, gender is going to play a part in bladder cancer, testicular cancer, and prostate cancer. Is it the same way that we think about what those issues are, or is it somehow another different? Same thing with, colorectal cancer. Again, not exactly the same part of the body, but it's down in the same region that we see a lot of those kind of gendered, ideas and ideals, particularly in relation to homophobia or fears about being associated with the LGBTQIA community, that for a lot of, certain groups of men that they don't really, it's part of their core identity is to make sure that it's very clear that they are not members of that community. And so that's in and of itself its own problem, but it also is something we have to understand if we're going to address those kind of issues.
It's interesting what you said about women's role as well, and I was thinking in terms of the doctors themselves. I think that plays a part, because when I've been to the doctor, I mean, I'm in my 60s, I've had the precise examinations that you're talking about, and the women doctors seem to me to be perfectly at ease with undertaking this kind of examination. The male doctors are much less so, which fits in with kind of what you're saying, and we're all affected by these gender, relations more broadly, aren't we?
Yeah, and I think that is part of what I mean by some of these things are missed. Like, we kind of don't realize that the same ideals that are contributing to how we see and understand people, both in terms of, going back to intersectionality, both in terms of how they understand gender and what those factors are, but what are the other things that intersect with gender that, may shape how you understand why this person is in front of you if you're a healthcare provider, and what we need to do with them. And so it really does, for a lot of men, they have that same kind of discomfort with providing some basic sort of test that they, they'd just rather not. And they look, some cases look equally or more uncomfortable than you do. From having had to do it.
Come on, doc,
Right.
But anyway, but thinking more generally, I mean, are there ways that you can, tell us about from your research about how to engage, meaningfully with marginalised groups such as black men and boys in the US? Are there particular ways that we should be approaching them in terms of health?
Yeah, I think it is just some of the basics are, I think what you would do for anyone in terms of treating them with respect, making sure that you ask if they have questions, making sure that you ask questions that may push the conversation. Because for some, we found that their they won't volunteer information, or we won't volunteer information. We're expecting the doctor to do some kind of mind reading that, you have to ask the right question to get somebody to talk about particular symptom that may not be obvious for them to talk about, but they're expecting, well, you're the doctor, you're supposed to know to ask about XYZ. And it's like, well, why would I think that when you haven't brought that up or something related to that as a symptom that you would have? I think sometimes it can be, recognizing just the what are the other factors, the contextual factors in their lives that are contributing to things. It becomes a slippery slope if folks don't do it well, because it can again feel make the physicians and the healthcare system feel hopeless when you're raising issues about people's lifestyles, constructional conditions that you can't do anything about, but that part of what you're doing is working with your patient. You're being a partner with your patient to say, okay, well, I understand you live in a food desert, or you live, that your employment is a bit more tenuous, that recognizing, okay, that is going to be a source of stress for you. So you really need to pay attention to when you're getting, you may or may not use the word anxious, but when you're realizing that there's some potentially some stressors in your life related to that, pay attention to how you eat, pay attention to what you do that may be at a higher rate than what you did before. So if you realize you're eating different things, you're smoking whatever, drinking more, doing those behavioral things that you're using to soothe yourself at higher rates when you're under stress, it's kind of helping them sort of understand these things in ways that are just good practice to help people connect those dots. In general, I don't know that it's really that different than what I would expect and hope doctors would do for anybody. That you really are treating the whole person, and that you're trying to make sure you really think about just the breadth of who they are and the totality of who they are. One of the things that makes your question great but also challenging is that, having a particular racial ethnic identity, we don't want to assume that that is actually the primary identity through which you see the world. So if you are, a member of the military, if you're a member of a particular religious faith and faith tradition or something like that, again, you may be gay, bisexual, trans, queer. That may be a more central part of how you see the world and how you interact with the world than necessarily what, you checking the box that says a man, woman, or not. So, like, those kinds of things, and recognizing that those other aspects of identity, that the racial and ethnic part is only part of who you are. But we don't want to sort of make the assumption that that is the main part of who you are, even though we recognize that from a looking at the environment where you live and work and so forth, that probably does play a big part. It's not the way you necessarily are going to see the world.
I think I was just interested in, Derek, something you mentioned earlier about perhaps the role of fatherhood, that perhaps that can sometimes be quite, I think you've done research on this, haven't you, can be quite an effective, or can be a kind of something which can have an impact on men, and perhaps, that engaging in caring relationships for others can help us to improve our own kind of self-care as well. Did you want to say anything about that?
Yeah, no, it's definitely something we've done a little bit of work about. It is an intriguing area that I think there's not enough work and attention to. And again, as we were talking about men in healthcare and so forth, that we're starting to recognize that, expectant and new fathers need actually services, need actually resources that are geared to them. It's not enough to just give them the same thing that you're giving the mothers, or just give them some more watered down version of what you're giving expectant and new mothers, that they really do need something that is uniquely designed for them. And so, again, we screen for, pre and postnatal depression in mothers. We don't tend to screen for that in men, but if you think about the stressors, the changes, the life changes, how they're seeing somebody that they may have some relationship with and some feelings for, that is going through all these changes and struggling, with all these different things, that is anxiety provoking, making a new human, and that all that kind of comes with it. And can I live up to what I think a father should be and what that role and responsibility means? That can cause anxiety, stress, and those kinds of things. So I think thinking about fatherhood from that role standpoint and what that means for how men see themselves is definitely something that we need to pay more attention to. The work of folks like Cleopatra Caldwell, who was at, I think she just recently retired from University of Michigan School of Public Health, had done some work because she had done a project with not new and expectant fathers, but non-resident fathers and their sons, and found that the focus was supposed to be on the behavioral, the sons. I think these were pre-adolescent sons, and their school behavior and trying to get those kinds of things under control. But what they found was that the fathers were often making changes to the way that they functioned and the way that they operated because they wanted to be better role models for their sons in the context of that intervention. And so she actually then did, I believe, a subsequent intervention that was using the same model, but really leaning into how do we need to support fathers to make these kind of changes, since they see that as a very important thing that they're doing for their families writ large. And so it wasn't just about father-sons, it was father-children and so forth, but it was how do we support fathers in making those changes? Because we often, did find, or other people have done more of this work, but have found that, the taking on the role of a father is something that really can make certain men really rethink their identity, who they are, what's important to them, and so forth. And so it really does have implications. It can be a key moment where we can get men to make certain changes that are really about sort of how they understand, the world, and what are they trying to basically do to, what's the message that they want to send about who they are, what kind of, contributions they made to the world, and so forth.
Well, thank you, Derek. It's so fascinating to talk to you and to learn about the complexities of these issues. But yeah, thank you so much for giving up your time.
Yes, thank you.
Truly
I've really enjoyed our conversation and learned quite a lot from it, so thank you.
Yeah, me too. Yeah. Thank you both. Yeah.
Well, Sandy, I certainly learned a lot from Derek there. I think, it really highlights the huge impact that society has on our health and well-being, really, doesn't it? And these huge disparities which exist in society in terms of the health differences between different groups of people and the inequalities there. But I think something which I found interesting was how he talked about, the impact that that masculinity has on men's health. And I think it was an interesting point he made that, perhaps sometimes we can, when we're talking about that relationship, we can slip into perhaps talking about it in ways which are quite individualized, that how masculinity can affect individual men's behavior. And perhaps we don't take enough of account of the fact that actually these are structural problems, really, and how, masculine gender norms are embedded in our institutions. And actually, that's where we need to, change things as much as we need to change things in the behaviors of individual men and boys to improve their health and well-being. What did you make of the conversation?
Sure, I agree with you. And, obviously his focus on intersectionality is really important and needs to be addressed. I mean, obviously his focus primarily seems to be on the health of Black American men, and I think Latino men to an extent, although he didn't really say so much about that. But I was thinking also in the UK context, and perhaps he didn't mention this so much because there wasn't time, but I was thinking more about social class and the importance of that, And we know in the UK that, mortality rates have fallen for all groups of men since about 1930, but they've fallen disproportionately much more for those in better off groups, actually. So social class, particularly in the UK, I think, which is such a class-ridden society, still has a huge impact. And going along with that, there's also geography as well, which we didn't really address. So we know that, for example, men in Glasgow, I think, probably live about 10 years less on average than men in Westminster in London. So there are different aspects to intersectionality, which also need to be brought into play as well, don't they?
Yeah, I was actually thinking about, there's a book by a US academic called Jonathan Metzl called Dying of Whiteness. So it's interesting to think about white men in that context you've just described as well, isn't it? In the US, for example, and he talks about actually how clinging to these ideas about whiteness and masculinity, that some men, perhaps maybe especially from more working class backgrounds, for example, might be voting for politicians who are actually having a damaging effect on their own health and well-being, with policies like not increasing restrictions on guns, and obviously the huge numbers of deaths, not just from gun violence, but also from suicide by guns. So it's fascinating how this can affect different groups of men, for example, and the role that race plays there. Yeah.
I mean, another thing that I don't think was mentioned was, not specifically, was the differences in the health of men depending on their sort of partnership status, if you like. So, it's generally true that married men do better than single men or even cohabiting men, and I mean, probably a variety of explanations, but one of them is the care provided by women to married men, So, that's another whole set of distinctions which need to be taken into account, particularly the position of single men, I think, as well, and men who are living on their own, especially in later life, are quite often prone to depression, and I think that does intersect with their poorer health outcomes.
Yeah, exactly. I mean, this is all so relational, isn't it? Like, relationships make a huge difference to men's lives, to their health and well-being, not just in terms of things like loneliness, but as you said, like, and as Derek said, about the fact that women often will be the ones who will push men to actually finally go to the doctor, for example.
Yeah. Well, I thought the example that we talked about prostate cancer was particularly relevant there, wasn't it? Because, these are areas that many men feel uncomfortable about. And so it's perhaps unsurprising that it's quite often the women in their lives who say, you do actually need to go to the doctor and have yourself checked out. And
No, I was interested in what you said as well about the fact that these are checks which you've had to.
Well, indeed. I mean, there's obviously genetic element to this as well. I mean, my dad died of prostate cancer. I mean, it's possible to live with prostate cancer for a number of years as he did, but and of course, going along with that is the fact that men are generally living longer. They're living long enough to get prostate cancer, but most of them die with it rather than of it. So I've seen that process as well, and given that background, I think it's incumbent on me to do something about my own health checks. So
and I know a few men in my life as well who've had those issues, and it is interesting, isn't it, for older men, I suppose, that when you start to deal more and more with these kinds of issues and the fears and anxieties and sense of vulnerability increasing that must come with that, and how that must be really confronting and difficult to deal with when society and ideas about masculinity haven't necessarily equipped you very well to be able to handle these things.
Well, and also that there are a number of possible treatments, some of which, as I think Derek said, can lead to lifelong problems of incontinence, sexual dysfunction, and so on. So, you can see why men might be reluctant to get checked, and yet actually their life might depend on it.
Yeah, absolutely. Well, that's a very interesting conversation. But we should probably stop there. But thank you so much, everybody, for listening. As always, if you haven't already, please do subscribe to Now Men wherever you get your podcasts, and we'll be back with another episode soon. Contact us at nowmen@gmail.com if you have questions or comments, and take care of yourselves.
Good night, everybody.
Or good day. Or good day. Thank you. Bye
now.